Welcome to e-learning for thoracic anesthesia. This session takes 60 minutes to complete. The content is suitable for anesthesia nurses and Year 1 to 3 anesthesia residents. We hope you find it useful. Overview. In this learning exercise, we will cover the spectrum of thoracic surgical procedures and explore the important points for pre-operative assessment. Methods for lung isolation are detailed, as well as anesthesia for non-intubated VATS. Management of intraoperative crisis such as hypoxia and ventilation strategies are explained. The final section briefly covers options for perioperative analgesia. We can't cover everything in great detail, but we should be able to present most of the key points that are important for thoracic anesthesia. In addition to lungs, thoracic surgery operations can involve the airways, mediastinum, pleura, chest wall, diaphragm, or esophagus. Airway surgery involving the trachea or main bronchi include tumor debulking, stenting, and tracheal resection. These procedures require use of a rigid bronchoscope, making the airway a shared and open one. Close collaboration with the surgeon is required, and specialized ventilation techniques like high or low-frequency jet ventilation is used. Low-frequency jet ventilation can be delivered by a Sanders jet, whilst the monsoon ventilator is used to deliver high-frequency jet ventilation. Mediastinal surgery can be complex, especially with large mediastinal masses. Careful consideration needs to be given to airway, ventilation, and hemodynamic management. Most thoracic surgery is done via VATS, which can either be multiport or more commonly uniportal. This approach to minimally invasive surgery avoids thoracotomy, which is known to be one of the most painful surgical procedures. VATS requires one lung isolation and ventilation in order to provide good operating conditions for the surgeon. Most lung resection and mediastinal surgery, with the exception of pneumonectomy, can be done via VATS. VATS surgery is carried out with the patient in the lateral decubitus position. Access to the thoracic cavity by sternotomy or thoracotomy is used for resection of large mediastinal masses, retrosternal goiters, and pneumonectomy. The posterolateral thoracotomy is the gold standard for obtaining access to the chest cavity. The incision extends from between the scapula and midspinal line, and extends laterally to the anterior axillary line. Other approaches include the anterolateral and axillary thoracotomy. We will now explore pre-operative anesthesia assessment for the thoracic surgery patient. Preoperative assessment is used to identify patients at elevated risk. We can use this risk assessment to stratify perioperative management and focus resources on high-risk patients to improve their outcome. Thoracic patients are often elderly with significant coexisting comorbidities. Geriatric patients are at a high risk for cardiac complications, particularly arrhythmias, following large pulmonary resections. Preoperative exercise capacity is a good predictor of post-thoracotomy outcome in the elderly. Prevalence of smoking is high, and cessation has been shown to reduce the risk of perioperative complications in high-risk patients. Cancer patients need to be evaluated for the 4 M's: mass effects, metabolic effects, metastases, and medications. Decortication surgery for empyema can be challenging as these patients are often septic. Younger patients with pneumothorax may have connective tissue disease like Marfan's, with coexisting cardiac abnormalities which need evaluating. Airway assessment will alert the anesthetist to potential difficulties with implications for method of lung isolation used. In addition to clinical assessment, the chest X-ray and CT thorax provides vital additional information for airway management and endobronchial intubation, especially when dealing with mediastinal masses and lesions causing extrinsic compression or intrinsic obstruction of the major airways. Previous bronchoscopy reports should be evaluated to obtain information on tracheal and bronchial anatomy, which will alert the anesthetist to potential difficulties. The major cause of perioperative morbidity and mortality in the thoracic surgical population is respiratory complications. Major respiratory complications such as atelectasis, pneumonia, and respiratory failure occur in 15 to 20% of patients and account for the majority of the expected 3 to 4% mortality. The best assessment of respiratory function comes from a detailed history of the patient's quality of life. Patients should also have baseline spirometry preoperatively to measure forced expiratory volume in 1 second, FEV1, and forced vital capacity, FVC. Cardiac complications are the second major cause of morbidity and mortality. Cardiac arrhythmias and myocardial ischemia or infarction account for the majority of these. Patients with risk factors for IHD with good functional capacity do not warrant further testing. In contrast, patients with poor functional capacity and predictors of IHD should have non-invasive testing of myocardial perfusion at rest and during stress. Patients with a normal MPI or less than 20% reversible perfusion defects may proceed for surgery. Further investigations with CT coronary angiography and/or cardiac catheterization is required for those patients with major reversible perfusion defects. Discussion with cardiology and surgeon for planning is needed in these cases. Atrial fibrillation can occur in 30 to 50% of patients post-operatively. Risk factors include age, extent of lung resection, pericardial dissection, and blood loss. Pulmonary function testing is used to quantitatively assess patients for lung resection surgery. FEV1 allows for assessment of respiratory mechanics while DLCO is used to assess lung parenchymal function. For pre-op assessment, FEV1 should always be expressed as % of predicted volumes, corrected for age, sex, and height. An example of results obtained from APFT is shown. The best result from a trial of 3 attempts at spirometry is used. FEV1 has been shown to be the best predictor of post-operative respiratory complications, which are a major cause of morbidity and mortality in thoracic surgery. This information allows us to identify high-risk patients that may benefit from pre-op interventions such as pulmonary rehab programs. In general, a baseline FEV1 of more than 2 liters indicates suitability for pneumonectomy while a value greater than 1.5 liters is accepted for a lobectomy. Patients with FEV1 greater than 80% predicted usually require no further workup and can proceed for surgery. The value of importance is of course the predicted post-op FEV1 or PPO FEV1. The lungs consist of 5 lobes, 3 on the right and 2 on the left. It can be further divided into segments as shown in the image. The predicted post-op FEV1 can be calculated based on how many segments or lobes are resected during lung resection surgery. Using the formula shown, we can calculate the PPO FEV1 of a patient undergoing lung resection surgery. In the example, this patient is predicted to have a post-op FEV1 of 32% following a left pneumonectomy. PPO values of less than 40% are indicative of high risk of post-op pulmonary complications. In the same manner, a PPO-DLCO value of less than 40% predicts high risk for post-op cardiac and respiratory complications. Further testing of cardiopulmonary reserve can be obtained with maximal oxygen consumption, VO2 maximum. A value less than 15 ml per kilo per minute or inability to climb more than 2 flights of stairs is considered to be a good predictor of post-op complications. We can summarize the quantitative pre-op assessments into a 3-legged stool consisting of evaluation of respiratory mechanics, cardiopulmonary reserve, and lung parenchymal function. We can use this information to guide anesthesia management as shown in the figure on the right. In the next section we will go through airway anatomy and methods for lung isolation. The trachea arises at the lower border of the cricoid cartilage as a continuation of the larynx. It travels inferiorly and bifurcates into the right and left main bronchi at the level of the sternal angle. It lies anterior and slightly to the right of the esophagus. Its width is approximately 22 to 24 mm in adults. The major airways are held open by C-shaped cartilage rings supported by the trachealis muscle posteriorly. The right main bronchus is wider, shorter, and descends more vertically compared to the left. The RMB is about 2 to 2.5 cm in length while the left is 5 cm. The primary bronchi further divide into lobar, or secondary bronchi and subsequently into tertiary, or segmental bronchi. The right lung has 3 lobes while the left has 2 lobes. There are 3 different methods that can be used to achieve lung isolation and OLV. Double lumen tubes, bronchial blockers, and single lumen tubes advanced into either the right or left main bronchus. DLTs are either right-sided or left-sided. Right-sided tubes have a Murphy's eye to allow ventilation of the right upper lobe. Different designs of DLTs are available, and they come in different sizes, ranging from 26 French for use in children above 8 years of age to 41 French for large adult males. Commonly used bronchial blockers include the Univent and ARNT blocker. These are described later. DLTs are bifurcated tubes with separate tracheal and endobronchial lumens, allowing for independent ventilation of either lung. The tracheal lumen terminates above the carina, while the bronchial lumen is angled to fit the appropriate main bronchus. The bronchial cuff and pilot balloon line is colored blue for easy identification. Right and left DLTs differ in their design because of anatomical differences between the main stem bronchi. The right main bronchus is shorter, straighter, and wider than the left main bronchus. Additionally, the right upper lobe bronchus takeoff is very close to the origin of the RMB. It is for these reasons that right-sided DLTs have a modified cuff and side opening in the endobronchial tube to allow ventilation of the right upper lobe. A left-sided DLT is shown here along with angled connectors for connection to the anesthesia breathing circuit. DLTs have 2 concave curvatures, located proximally and distally along the tube. A stylet is used during intubation to maintain the curvatures. The tubes are D-shaped in cross-section and the internal diameter of each lumen is significantly smaller than a correspondingly sized SLT. Left-sided tubes are most commonly used and less contraindicated as they are easier to insert. As mentioned previously, the right-sided DLT has a distal side opening to allow for ventilation of the right upper lobe. This is shown in the image. Right-sided tubes are more difficult to position correctly as the Murphy's eye needs to be in alignment with orifice of the right upper lobe secondary bronchus. Fiber optic bronchoscopy must be used to confirm correct positioning of the right DLT. Incorrect alignment of the Murphy's eye will lead to right upper lobe collapse and hypoxia. Two methods can be used to insert DLTs. After checking the integrity of the tracheal and bronchial cuff, both cuffs are completely deflated and the DLT is lubricated. A stylet is used to maintain the distal curvature of the tube. Visualization of the larynx by conventional or video laryngoscopy is then performed. The endobronchial tip is inserted beyond the vocal cords and the stylet is removed. The tube is then rotated 90 degrees clockwise or counterclockwise depending on the side of placement. The tracheal cuff is then advanced into the trachea, beyond the glottis until resistance is encountered. This is blind insertion of DLT. Alternatively, DLTs can be inserted under direct vision with a fiber optic bronchoscope. Once the lumen of the DLT is within the trachea, an FOB is passed into the endobronchial lumen of the DLT. The FOB is used to visualize the carina. The bronchoscope is passed into the right or left main bronchus and finally the DLT is railroaded over the bronchoscope into position. Insertion of DLTs under direct bronchoscopic guidance has the advantage of allowing any anatomical or pathological abnormalities of the major airways to be detected at the point of insertion. This can avoid accidental trauma to the airways. Once inserted, correct placement of the DLT must be confirmed. This can be done clinically or by fiber optic bronchoscopy. The 3-step method of sequential clamping and auscultation is used for clinical confirmation. Step 1. Inflate the tracheal cuff to seal the glottic leak. Confirm bilateral air entry and acceptable capnography trace. Step 2. Clamp the tracheal side of breathing circuit and disconnect the tracheal limb from the DLT. Inflate the bronchial cuff with 1 to 3 ml of air. Confirm unilateral air entry and no audible air leak. Step 3. Release the tracheal lumen clamp and close the port. Confirm bilateral air entry once again. This completes clinical confirmation. The gold standard for confirming correct DLT placement is with fiber optic bronchoscopy. Clinical confirmation also cannot be used to reliably confirm placement of a right-sided DLT. For left-sided DLTs, insert the bronchoscope via the tracheal lumen to visualize the carina. The endobronchial blue cuff should be seen as a thin crest in the left main bronchus. It should not herniate out of the bronchus and obstruct the trachea. The cuff can then be inflated under direct vision. In addition to the previous steps, confirmation of right-sided DLTs require the bronchoscope to be passed into the right endobronchial lumen. This is done to ensure that the Murphy's eye is directly opposite and well aligned with the orifice of the right upper lobe secondary bronchi. Bronchoscopic confirmation is often the only way to check placement of DLTs once surgery has commenced. Malpositioned DLTs can cause collapse of the ventilated lung or inadequate collapse of the operated lung, leading to hypoxia or poor operating conditions. Common causes of tube malposition include cuff herniation due to overinflation, dislodgement during patient positioning, coughing, or surgical manipulation of the carina or main bronchi. Left-sided DLTs are most commonly used unless contraindicated. Distorted anatomy of the left main bronchus by external compression or intrinsic lesions may prevent use of a left DLT. Other indications for a right-sided DLT include left-sided pneumonectomy, sleeve resection, and left-sided lung transplantation. Adult DLTs come in a range of sizes from 35 French to 41 French. The French gauge refers to the external diameter of the tracheal lumen in millimeters multiplied by 3. A properly sized DLT is one that passes easily through the glottis and advances without resistance within the trachea, with the bronchial component passing into the intended bronchus without difficulty. The most accurate method of selecting the size of the DLT uses measurements of the left main stem bronchial diameter from a CT scan. A traditional approach would be to use 37 and 39 French DLTs for average-sized female and male patients respectively. An oversized or undersized DLT that has migrated distally can rupture the membranous portion of the trachea or bronchus. Iatrogenic airway trauma can present as unexplained air leaks, subcutaneous emphysema, massive bleeding or protrusion of the tube into the surgical field. Proximal migration of a DLT with cuff herniation into the trachea will lead to high airway pressures, sudden loss of capnography trace and inability to ventilate the lungs. For these reasons, correct placement of the DLT must be confirmed after initial insertion and after any patient positioning maneuvers. It is prudent to also check the position of the DLT before lung isolation and start of surgery. Problems related to tube malposition used to be a common feature of thoracic anesthesia and accounted for significant morbidity and mortality. These issues have largely been overcome by use of fiber optic bronchoscopy. Access to fiber optic bronchoscopy must be available throughout surgery, from induction of anesthesia to skin closure, as problems with tube malposition can occur at any stage. The second method for lung isolation utilizes bronchial blockers, which come in a variety of designs. We will review the three main types of bronchial blockers in common clinical use. These are the Univent blocker, Arndt blocker, and Cohen blocker. Bronchial blockers may be inserted within a single lumen tube or coaxially. Alternatively, they may be placed external to the lumen of the SLT or independently. Another design consists of an SLT with a bronchial blocker already pre-incorporated into the internal lumen of the tube. This is called the Univent tube. Bronchial blockers work by occluding the main stem bronchus, thereby preventing ventilation distal to the occlusion. In addition, blockers can be used to provide selective lobar collapse as well. The uniblocker is a torque control blocker. Unlike other bronchial blockers, the shaft of uniblocker is made from wire mesh coated with polyurethane, ensuring that any manipulation is translated to the tip of the blocker in a 1-to-1 ratio. Together with its fixed distal curve, the unique design of uniblocker maximizes control during insertion and facilitates blockade of the left or right bronchus through a standard single-lumen endotracheal tube. The uniblocker enables both full lung or selective lobar blockade during OLV. Lung isolation can be carried out even in patients with difficult airway or tracheotomies. Easy removal is facilitated without disconnection from the anesthesia circuit. The central lumen of the uniblocker allows for air to be aspirated, thus facilitating collapse of the non-ventilated lung. CPAP or oxygen insufflation can also be delivered to the non-ventilated lung if hypoxia is an issue. The ARNT blocker is positioned in the desired bronchus using a wire loop, which couples the blocker with a fiber optic bronchoscope. Wire-guided blockers cannot be inserted blindly. The wire loop needs to be removed in order to allow for lung deflation or delivery of CPAP. The wire loop once removed cannot be reinserted in 5F and 7F blockers, making repositioning of the blocker difficult.
The ARNT endobronchial blocker is intended for endobronchial blockade of the left or right lung for procedures which require one lung ventilation. One lung ventilation is commonly required for surgical procedures and is normally achieved using a double lumen endotracheal tube.
One of the advantages of using this blocker set is that it can be used with a conventional endotracheal tube. The 3 millimeter diameter does not significantly compromise the cross-sectional area of the endotracheal tube, such that there is no noticeable change in resistance to airflow through that endotracheal tube. In terms of the quality of the surgical exposure using a bronchial blocker, in general our surgeons are similarly happy with the field exposure experienced with the use of a double lumen tube as they are with the endobronchial blocker. The placement of the blocker does require adequate lubrication, and I think the lubricant of choice in this situation is an aerosolized silicone spray. The other gel-type lubricants can interfere with the optics of the bronchoscope as the bronchoscope is passed through the endotracheal tube.
A special bronchoscopy port, the ARNT multi-port airway adapter, allows simultaneous bronchoscopy, ventilation, and endobronchial blockade. Assembly of the device is straightforward. With a conventional endotracheal tube correctly placed above the carina, the ARNT multi-port airway adapter is attached to the tube. It then connects to a standard anesthesia circuit, and the patient is ventilated with 100% oxygen. The ARNT endobronchial blocker uses a monofilament guide loop assembly, which fits through the lumen of the endobronchial blocker and exits from the blocker's distal end to form a small, adjustable monofilament loop. A pediatric fiber optic bronchoscope is advanced through the guide loop to couple the bronchoscope and the endobronchial blocker together. This may be done within the multi-port adapter, endotracheal tube, or within the trachea proper. The endobronchial blocker and bronchoscope may also be coupled together prior to attachment of the multi-port adapter to the endotracheal tube. This coupling allows the endobronchial blocker to follow the bronchoscope. The guide loop can be adjusted to facilitate proper approximation. Once the carina is visualized, the bronchoscope is advanced into the section of the lung which is going to be deflated. After the area to be blocked is entered, the bronchoscope is held stable and the loop with the endobronchial blocker is advanced and pushed off the end of the bronchoscope. After slight retraction of the bronchoscope, the endobronchial blocker may be either advanced or retracted to place it in final position. Under bronchoscopic vision, the balloon is inflated with air using the pilot balloon assembly. The balloon should fill the entire endobronchial lumen to be blocked and not herniate into the main stem trachea. The lung should be carefully auscultated following initial bronchial blocker placement and balloon inflation to ensure proper functioning of the endobronchial blocker. If ventilation should be acutely difficult during endobronchial blockade, the balloon should be immediately deflated. The bronchoscope can then be withdrawn. The blocker port of the multi-port adapter is tightened, ensuring that there is no escape of gas and that the blocker does not move within the multi-port adapter. After assuring that the blocker is in the correct lung, the balloon is deflated and the bronchoscope port closed. The patient is positioned for their surgery, and once again the balloon is inflated to allow the surgery to proceed. It is important to deflate the balloon prior to final positioning of the patient, because some movement of the endotrachea or carina can occur. Once the position is confirmed, the guide loop can be withdrawn from the central lumen of the blocker and the lung deflation can begin. The guide loop assembly cannot be replaced within the endobronchial blocker once it has been removed. Once the loop is removed from the blocker, the lung will deflate both passively and through absorption atelectasis. In addition, deflation can be assisted by direct aspiration with a syringe. The blocker's central lumen can also be used to deliver CPAP with the enclosed adapter.
Well, there are several indications for the use of a single lumen tube with an endobronchial blocker set, and I use it in both the setting of thoracic surgery as well.
Available in 5 French pediatric spherical, 9 French spherical, and 9 French elliptical sizes, the ARNT endobronchial blocker is a new tool to achieve direct visualized one-lung ventilation using a standard
Another device which incorporates a bronchial blocker and a single lumen tube into a single device is the Univent tube. A thin lumen in the blocker itself allows for lung deflation and delivery of CPAP, or oxygen insufflation in the blocked lung. High pressures generated by the bronchial cuff, and higher cost than that of double lumen tubes, are two other factors that limit the use of the Univent tube. The Cohen blocker uses a wheel device to deflect the tip of the blocker, to assist with endobronchial insertion. A comparison of the 3 commonly used bronchial blockers is presented in the table. Pediatric sizes are available for the Fuji Uniblocker and ARNT blocker. The ARNT blocker also comes with spherical or elliptical shaped balloons, which may be useful for situations where lung isolation is difficult due to anatomical variations. Both the Uniblocker and ARNT blockers are available for use in NUHS. Bronchial blockers are generally used for patients with an expected difficult airway, or when an unexpected difficult airway is encountered. Single lumen tubes are frequently easier to insert in difficult airways, due to their smaller diameter and less bulky construct. Other common indications for blocker use include already intubated patients, patients with tracheotomies, and situations where postoperative ventilation is required, such as in minimally invasive cardiac surgery. Of note, bronchial blockers do not protect against contamination by blood, secretions, or pus from the opposite lung. In these situations, a DLT should be used. The respective advantages and disadvantages of the 2 lung isolation methods are outlined here. Bronchial blockers are more costly compared to DLTs. They also require the use of fiber optic bronchoscopy for insertion. DLTs can be inserted blindly and position confirmed clinically, although this is less desirable. A major disadvantage of the blocker is ease of dislodgement during patient positioning or during surgery. Constant vigilance is required, and repeated repositioning may occasionally be required in the problematic patient. Other issues include slow or incomplete deflation of the non-ventilated lung due to the narrow central channel of blockers.
Is fundamental that we have a good understanding. Here we're doing a fiber optic bronchoscopy through a single lumen endotracheal tube. And as we exit from the tube, we see the longitudinal fibers in the back wall of the trachea, the rings and the top, left and right bronchus. You can see the takeoff of the right upper lobe. We're going to enter the right bronchus and go into the right upper lobe and see the 3 segments of the right upper lobe. And then the bronchus intermedius and the middle and lower lobes are clearly visible. The relation between the carina and the right upper lobe is very important to keep in mind when you use bronchial blockers. We're going to enter the left bronchus, which is usually around 5 centimeters in length in the adult. You see the 2 lobes clearly visible, their entrance. And so using the blockers on the left side is very easy. On the right could be a little difficult. Longitudinal fibers again, tracheal rings in red, the right and left bronchus, and right upper lobe takeoff in red arrow to point in the carina. This relationship is very important when you use blockers. There are different techniques to isolate. It could be blockers or double lumen tube, and even the Fogarty catheter can be used. The diameters of different tubes, single lumen, univent, and double lumen tubes are in this slide, and you should take the time to see the slide in detail. Right-sided double lumen endotracheal tube's anatomy. So you can see it has a Murphy's eye, the bronchial ending, which is the blue, and it has also a distal opening. The cuff is shaped in a way that will facilitate blocking the right bronchus, and it has a distal ending, yellow is the Murphy's eye, and then the red, the distal bronchial lumen, and black, the tracheal lumen, a thin black arrow. We do bronchoscopy through a tracheal opening of a right-sided double lumen tube. Place the bronchial lumen inside the right bronchus. As you can see, the cuff is not visible, so this was probably a little too far in. It will be pulled out a little bit, so you can see part of the cuff. And then bronchoscopy should be done through the bronchial lumen to confirm that the Murphy's eye is in front of the right upper lobe. That way, the right upper lobe is not blocked by the right-sided double lumen tube. So I said we will not present this as a limitation over Manikin. We're now doing a right-sided double lumen tube, placing it through or over a fiber optic bronchoscope. The bronchoscope is in the right bronchus. The tube is slid over. As you can see now, the tube is in the right bronchus. And at this time, we should take a look at the Murphy's eye to see its relationship with the right upper lobe to make sure they face each other. Left-sided double lumen endotracheal tubes are easier, almost always placed instead of the right, as there is a little more difficulty to place the right tube. The left side has an angle in the bronchial lumen. It has no Murphy's eye, two openings, distal and red, and then the tracheal opening in black. Almost always the left-sided tube is placed instead of a right-sided, unless there is a contraindication to a left-sided tube. We're doing now bronchoscopy, placement of a double lumen tube with the bronchoscope through the bronchial lumen. Bronchoscope will go into the left bronchus, and the tube will be slid over. Normally, double lumen tubes are placed initially blindly, and then position confirmed by auscultation, and ideally with bronchoscopy. Now we're going to take the bronchoscope through the tracheal lumen and see the position of a left-sided double lumen tube. You can see the cuff is a little too far out, a little herniating into the trachea. The tube will be pushed in with the cuff still deflated, and then the cuff will be inflated. This will be the ideal position of a left-sided double lumen tube. The cuffs are inflated only until there is no leak to minimize the tracheobronchial damage due to overpressure. And the bronchial blockers, there are several options, including Fogarty catheter, not depicted here. Cohend, Arndt, and Univent. Univent, as you can see, there are two versions. One that has a Univent tube and a right oral commissure for the right blockers. Second version of the Univent tube, you have much better torque control. As you rotate proximally, you see how the blocker translates the motion in a smooth fashion. It's easier to control. Notice always, though, the ventilatory lumen of the Univent tube is much smaller than a corresponding tube of similar size of single lumen tube. Again, bronchoscopy, tube to main carina relationship confirmed, the tube is secure, and then the blocker is deployed. I like to inflate the blocker's balloon under pressure control ventilation, realizing that when you occlude one lung, if you occlude the right lung, the tidal volume will decrease to a little less than half, and if you occlude the left bronchus, the tidal volume will decrease to a little more than half. That way I minimize the pressure in the blockers and risk of bronchial ischemia. Blockers are ideal. As you can see, this is a well-positioned blocker. When you do want to keep the patient intubated at the end of the case, and for all our minimally invasive cardiac surgery, the knees long isolation, we use blockers unless the takeoff of the right upper lobe is higher up than the carina or at the level of the carina, then we have trouble placing blockers. I'm talking about right-sided blockers. For left-sided blockers, it's usually no problem. It's easy, thoracic surgery or thoracoabdominal aneurysm, etc. Blocker in the left bronchus, it's too far out. We'll probably advance it a little bit more. Always remember the blockers can fall into the trachea and cause complete airway obstruction. One issue to always keep in mind, if you see a sharp decrease in the tidal volume or a sharp decrease in the airway pressure, always consider blocker herniation into the trachea and total airway. Consider the diameter of the tube, adding the bronchoscope. Arndt blocker, excellent alternative. It has a Prolene loop, through which the bronchoscope will be placed through. All blockers have centimeter markings, proximal portion, adapter for the arm blocker port, bronchoscope port, and then the T vertical portion is where the airway breathing circuit will be connected. Bronchoscope through the praline, and then the blocker will follow. The beauty of this blocker is that it has 3 different sizes, 5, 7, and 9 French. Here, bronchoscopy, we're going to put the blocker in the right bronchus, place the bronchoscope down in the right bronchus, and then the blocker is slid over as it emerges in front of the bronchoscopic view. You will see the praline emerging very soon, the top portion of the screen, and then the blocker will follow as we continue to advance the blocker. Here we go, praline and blocker. We then hold the blocker in that position and withdraw the bronchoscope to assess final correct position of the blocker. As I said, there are 5, 7, 9 French sizes, and this is the beauty of this blocker. Univent and the Cohen blockers only come in 9 French. Ideal blocker also to be used. It can be positioned on the left side. Sometimes the praline gets hooked in the bronchoscope, and that could be a little bit of difficulty doing that. A trick that you can use is you can take the blocker and actually bend its tip. The blocker has some memory, so only will last like 5 minutes. It's bent, but then when you use it as a univent blocker and rotate it and actually position it. It's patient with the blocker in place in the adapter. Excellent blocker. Cohen and the broncho blockers has a problem that the balloon is very big in relationship to the blocker and does not deflate completely flat to the blocker, so it can obstruct your way or your view. Here you see the tracheobronchial tree. The blocker will be deployed first in the right bronchus, and we'll advance the blocker. And you'll notice how the balloon takes a lot of our view, and in a smaller airway this could be an issue. The blocker being advanced in the right side. This blocker has a little wheel at the top that as we rotate it, the tip will bend following this black line you can see at 9 o'clock position. See also how the balloon tends to herniate on this blocker. That's another problem of the Cohen blocker. Another alternative though, always remember Fogarty catheters could be a useful alternative, although they don't have a lumen through which CPAP can be applied or suction can be done, or to facilitate the emptying of the lung. You can also empty the lung though by putting the blocker in the lung, disconnecting from the breathing circuit, detaching the patient, as I said, from the breathing circuit, and then inflating the blocker, and then reconnecting to the breathing circuit. So Cohen blocker in position. Excellent alternative as well, but our least favorite of the 3. Univent single blocker is our favorite. And of course, the balloon tubes continue to be the kings of the lung isolation techniques. Blockers can also be placed outside of the endotracheal tubes and
Hi, I'm Amelia. Ethan, whom you were listening to earlier, has gone on a break. Let's continue with the next section. NEVATS, or non-intubated video-assisted thoracic surgery, is currently being piloted in NUHS. NEVATS involves performing VATS surgery without lung isolation in spontaneously breathing patients. Surgery can be done under monitored anesthesia care, supplemented with regional anesthesia. In NUHS, patients undergoing NEVATS are given a general anesthetic. A supraglottic airway is used for airway management, thus avoiding the need for endotracheal intubation and its associated complications. Regional anesthesia is used in these cases with GA to provide a balanced anesthetic technique. These include paravertebral block, erector spinae block, or intercostal nerve blocks. What are the advantages of NEVATS? Some of the potential benefits include reduced airway trauma, decreased inflammatory response, and reduced barotrauma to the lungs, as positive pressure and one-lung ventilation are avoided. These can lead to better outcomes for patients in terms of faster recovery and earlier discharge from hospital. We can now look at our locally developed clinical guidelines for practice of NEVATS. These guidelines are available on the NUHS intranet in the Department of Anesthesia section. It outlines requirements for the safe practice of NEVATS and includes information on patient selection criteria, workflow, equipment required, and dealing with emergencies. As it's a new procedure for us, we are conducting training sessions for all AU and scrub nurses who may be involved. Patients for NEVATS will be identified by the thoracic surgeon. Anesthesia pre-op evaluation will be carried out in AOCC to confirm suitability. Exclusion criteria are extensive at present, but can be relaxed once we obtain experience in NEVATS and are confident with our workflow and clinical processes. Exclusion criteria include patients with severe OSA, morbid obesity, potentially difficult airway, poor baseline respiratory function, and patients with major systemic disease such as cardiac failure, end-stage renal failure, and liver cirrhosis. Complex lung lesions involving the major bronchi, chest wall or diaphragm are also excluded from NEVATS. Patients undergoing NEVATS are not paralyzed and are spontaneously breathing. Anesthesia needs to be tailored in order to provide surgeons with a stable surgical field, with minimal movement of the diaphragm, chest wall or mediastinum. On the converse, excessive depth of anesthesia may lead to hyperventilation, hypoxia and hypercarbia. A balanced anesthetic technique using TIVA and regional anesthesia is used, titrated to a respiratory rate of 12 to 20 and BIS of 40 to 60. The preferred supraglottic airway for use in NEVATS is either the Auragain or iGel, as these allow for passage of a fiber optic bronchoscope and bronchial blocker, should there be a need for conversion to one-lung ventilation. Coughing may be an issue during surgical manipulation. This can be dealt with by a vagal block, performed by the surgeon. A standard anesthesia plan for NEVATS is described here. This table shows the additional anesthesia and surgical equipment required for a NEVATS case. It is important that we have the airway trolley with listed equipment available in the OT at all times. To summarize, we will use either the Auragain or iGel supraglottic airway for airway management. The disposable ambuscope size 3.8 should be available in OT, although it does not need to be opened from packaging. A video laryngoscope must also be available at all times. Additionally, an adult-sized uniblocker and 37 French left-sided DLT should be available, should the need arise for conversion to one-lung ventilation. Also required are an ultrasound machine and regional block trolley, as well as 2 TIVA pumps. On occasion, there may be a requirement to convert from a spontaneously breathing patient to positive pressure ventilation and one-lung ventilation. This is estimated to occur in less than 5% of patients. The reasons for conversion can be broken down into surgical and anesthetic indications. Excessive mediastinal or chest wall movement may make operating conditions difficult, thus necessitating controlled OLV. Unexpected bleeding and dense surgical adhesions are other indications. Anesthetic indications include persistent hypoxia or significant hypercarbia, associated with respiratory acidosis or hemodynamic instability. Some degree of permissive hypercarbia is usually tolerated well by patients. In awake patients, GA may need to be induced if they are uncooperative or unable to tolerate surgery. Conversion to one-lung ventilation can be carried out by a number of methods. Often the technique chosen will depend on the patient and situation at hand. Outlined are 4 methods that can be used. Planner involves lung isolation using a uniblocker inserted through the supraglottic airway. The ambuscope is used to guide the blocker into final position, and the balloon is inflated under direct vision. The patient is paralyzed and one-lung ventilation proceeds through the supraglottic airway with blocker in place. Failure to achieve satisfactory lung isolation with this method leads us to Plan B. In Plan B, an appropriately sized endotracheal tube is railroaded over a bronchoscope through the supraglottic airway. We can proceed to block the appropriate lung once the endotracheal tube is in the trachea and ventilation confirmed. Lung isolation can be achieved with the uniblocker as previously described, or by passing the endotracheal tube into the appropriate main bronchus to be ventilated. The table shows ETT sizes for different sized supraglottic airway. If Plan B fails, an attempt can be made to intubate the patient in the lateral position, either with a single lumen endotracheal tube or double lumen endotracheal tube. The bed can be tilted slightly to bring the patient's head and airway to a more supine position. A McGrath or CMAC video laryngoscope should be used to visualize the glottis. A bougie can be used to facilitate intubation if required. In an emergency situation with impending or total loss of airway control and ventilation, an emergency maneuver to turn the patient supine to facilitate intubation must be quickly carried out. The phrase, "cover and turn," is used to alert all members of the team to the need to act quickly. The surgical wound is covered with ioban dressing before turning the patient. Once the airway has been secured, the patient is turned back to the lateral position to allow surgery to continue.
This video demonstrates one lung isolation with a uniblocker. The blocker is inserted through the supraglottic airway under direct fiber optic vision. This section covers key anesthesia issues relevant to intraoperative management in thoracic surgery. The flow chart outlines the management of patients with predicted or unexpected difficult airway. There are a number of options available to manage the patient with an expected or known difficult intubation. The safest option would be to perform an awake fiber optic intubation, either via the nasal or oral route, with a single lumen endotracheal tube. A bronchial blocker can then be passed through the single lumen tube and placed in the appropriate main bronchus for lung blockade. This is done under direct vision with an FOB. Alternatively, either a CMAC or McGrath video laryngoscope can be used to visualize the glottis to facilitate intubation. Adjuncts such as a bougie or airway exchange catheter can aid intubation here. A single lumen tube with a bronchial blocker can be used. Alternatively, a DLT can also be used to achieve lung isolation. In an unexpected difficult intubation scenario, or failure to intubate, ensure first that oxygenation and ventilation can be achieved either with a face mask or supraglottic airway. Intubation with the aid of an FOB or video laryngoscope can then be attempted. An SLT is usually used to intubate the patient in such cases. Lung isolation can then be achieved with a bronchial blocker, or by exchanging the SLT with a DLT using an airway exchange catheter. Hypoxemia during one lung ventilation has an incidence of 1 to 2% in modern thoracic anesthesia. This contrasts with a much higher incidence of 20 to 25% in the past. The lower incidence can be partially attributed to better lung isolation, which is routinely performed under direct vision with an FOB. Hypoxemia during OLV can be physiological, secondary to increased shunt, reduced FRC, or inadequate ventilation and increased dead space. These are explained later. Pathological causes are related to tube or blocker malposition, bronchospasm, excessive secretions or blood, air trapping, pneumothorax, or due to issues with the breathing circuit, anesthesia machine, and oxygen delivery. Predictors of hypoxemia during OLV include the following. Patients having right lung surgery or surgery in the supine position are at increased risk of hypoxemia. Other indicators include poor oxygenation during two-lung ventilation in the lateral position, good pre-op spirometry, young and healthy patients, and cases with a significant proportion of ventilation or perfusion to the operated lung are other predictors of hypoxemia on OLV. Hypoxemia can develop rapidly during OLV. Prompt recognition and management must be instituted. When faced with hypoxemia during OLV, the anesthetist must immediately alert the surgeon. Surgery should be paused and two-lung ventilation with 100% oxygen instituted, especially if oxygen saturations are rapidly declining. High airway pressures indicate a pathological cause of hypoxemia such as bronchospasm, pneumothorax, or more commonly endobronchial tube malposition. The anesthetic machine and breathing circuit should be inspected to exclude these as causes. The DLT or blocker position should be checked with bronchoscopy. Excessive secretions or blood are suctioned. Bronchospasm can be managed with inhaled bronchodilators delivered through the breathing circuit. Ensure adequate cardiac output and hemodynamic stability. We can conclude that hypoxemia is physiological once pathological causes have been ruled out. Other pointers to pathological causes include sudden deterioration in oxygen saturations. Physiological hypoxemia typically occurs gradually, soon after institution of OLV. Recruitment maneuvers to recruit collapsed alveoli and increase FRC are then instituted. Oxygen insufflation or CPAP can be applied to the non-dependent lung. 2 to 3 centimeters of water is usually sufficient. Excessive CPAP will lead to inflation of the operated lung and make surgery difficult. PEEP can be applied to the dependent lung to increase FRC and improve gas exchange. If these fail, intermittent two-lung ventilation is used. Other options include use of inhaled nitric oxide. Acute lung injury and ARDS are important causes of post-operative morbidity and mortality. The incidence is estimated at 1 to 2% following lobectomy, carrying a high mortality rate of up to 50%. Acute lung injury usually develops 1 to 3 days after surgery. Its incidence is also increased in fluid overload and pneumonectomy. Perioperative ventilatory strategies to minimize acute lung injury are outlined here. 1. Lung ventilation strategies to prevent acute lung injury and ARDS are somewhat based on critical care ventilation strategies for patients with ARDS. Traditional ventilation with 10 ml per kilo is northwest longer used and is recognized to predispose patients to lung injury. Adequate PEEP should be applied to the ventilated lung in order to prevent atelectasis. Too much PEEP, however, can lead to reduced pulmonary blood flow to the dependent lung, which increases shunt and predisposes to hypoxemia. A suggested lung protective ventilation strategy is outlined here. In general, tidal volume should not exceed 6 ml per kg. Plateau pressure should be kept below 25 centimeters of water. Inspired oxygen concentration should be titrated to maintain oxygen saturations above 92%. Use a lower FiO2 where possible. Recruitment maneuvers and PEEP are used to keep alveoli open and prevent atelectasis. Permissive hypercapnia is allowed. Minute ventilation can be increased by increasing respiratory rate, whilst maintaining tidal volume at 6 ml per kg during West LV. In this final section we will briefly cover options for perioperative analgesia. Analgesic options depend on type and extent of surgery. Analgesic requirements for minimally invasive surgery are quite different to open approaches such as midline sternotomy or posterolateral thoracotomy. In general, patients undergoing VATS can be managed with simple analgesics, non-steroidal drugs and 4 opioids. Regional anesthesia can also be used, either as a single shot or with a catheter. Commonly used blocks for VATS surgery include paravertebral or erector spinae block. These should be ultrasound guided. Surgeons often perform intercostal nerve blocks at the end of surgery. A non-Q pump with wound infiltration of local anesthesia may be used for patients needing unplanned conversion to thoracotomy from VATS. Patient-controlled analgesia. PCA morphine or fentanyl is reserved for patients needing sternotomy or thoracotomy. Thoracic epidural anesthesia used to be commonplace in the past when thoracotomies were routinely performed. Uniportal VATS has largely removed the requirements for this form of analgesia. To summarize, thoracic anesthesia is an interesting and challenging subspecialty of anesthesia. Surgical practice has evolved significantly in the past decade, with most operations being done by the minimally invasive route. NEVATS is feasible and may provide added advantages to patients with faster recovery and discharge from hospital. Thoracic anesthetists need to be competent in lung isolation techniques and advanced airway management. A good understanding of physiology of lung ventilation and awareness of potential complications of OLV is needed. Ultrasound-guided regional anesthesia techniques for perioperative analgesia are increasingly used, and skills in these techniques are required. We hope you have enjoyed this session. Further reading resources are provided here. Thank you.